Since taking up post as Minister of Health for Social Services and Public Safety, I have made driving forward improvement in emergency care services a key priority for my department. I have sought to build upon the foundations laid by my predecessor, Edwin Poots, including the establishment of the Unscheduled Care Task Group led by the Chief Medical Officer and the Chief Nursing Officer to oversee the implementation of the recommendations of the RQIA review of unscheduled care. The task group was set a challenging task to work with the HSC to prevent anyone from waiting unavoidably for more than 12 hours before being admitted or discharged from an emergency department this winter, and to ensure that the HSC improves the number of people admitted or discharged within 4 hours. These measures are very important. Waiting times can be long, and that can contribute to poor quality of care and outcomes for patients. However, there's much more to the quality of the services than just time limits or performance targets. We must remember that behind every one of these statistics there's a person, often a very vulnerable person, who deserves respect and compassion when they access our health and social care services. Mr. Chairman, there have been times our health service care system has been under pressure, has not lived up to these standards, resulting in patients waiting too long with the associated consequences for patient and staff. I am committed to ensuring that that situation changes. That is why, in addition to the comprehensive work being undertaken by the task group to prepare and improve our services this winter, my department has also begun to develop a set of values and principles which will underpin urgent and emergency care services. These were recommended by the RQIA in its review of unscheduled care at the Belfast Trust with regional learning implications. I will speak more on this later. The panel may be aware that on the 19th of November I made a statement to the Assembly updating them on the work of the task group. Whilst I recognise that much work remains to be done in a challenging financial context, there are nonetheless considerable achievements that have been made to date. These include the development of a regional unscheduled care escalation plan to ensure that there is a consistent and robust methodology for monitoring activity, moderating patient ambulance flows, and triggering escalation when necessary across the region, as well as work by individual trusts to review their own escalation plans, to provide an assurance of their robustness, including an assessment of their ability to respond over the Christmas and New Year period. The task group also focused on strengthening the services provided to our frail older population. This is a priority for me, and I've made it clear to my officials that I expect a key outcome of this process to be a service that's not only safe and effective, but also appropriate to the needs of our older people. There has been considerable progress to date, including work to deliver improvements in the transfer of information between nursing homes and EDs, and the development of standards of care for our frail elderly population to ensure they're not moved about the hospital unnecessarily or discharged appropriately late at night without their consent or their family's permission. I am pleased that the Belfast Trust has now established a project which will ensure that frail elderly patients can be directly assessed and admitted to the city hospital site. Patient and care feedback to date has been very positive. Health and social care trusts as a whole are also looking forward to extending direct access for other vulnerable groups such as the respiratory patients, and I welcome this. A key thematic finding of the RQIA report was the need to ensure effective patient flow both within and across hospitals and wider primary and community services. This fits with my department's overarching strategy approach of supporting people in their homes for as long as possible. We must avoid as far as possible patients presenting to hospital through the ED department when their needs can be better met elsewhere. The task group has taken a significant number of steps in this regard, including the development of a regional model for unscheduled care that identifies alternatives to ED attendances, particularly for older people and those requiring urgent assessment rather than emergency care. We are examining the provision of direct access to hospital-based assessment and admission services for appropriate patients. Trusts are also working with the Northern Ireland Ambulance Service and other transport providers at local level to improve non-urgent transport of patients. It is vitally important that we ensure that large numbers of patients are better dealt with elsewhere, do not present to emergency departments at any one time, as this can cause significant pressure and congestion and busy environments, potentially causing further stress to patients and staff. As part of our strategy to address this, the Health and Social Care Board has developed a locally enhanced service to support the general practitioners to commence home visits earlier in the day and bring forward the time of day patients are being referred to hospitals. An important part of the work of the task group is to develop and determine best practice and to ensure that it is rolled out across Northern Ireland. There have been a number of successes to date, including the development of audit tools to identify delays in the patient's journey and to monitor the fundamental aspects of nursing care in the ED. We are also developing regional approaches to multidisciplinary assessment at discharge and regional standards for triage nursing practice and emergency nurse practitioners to support nurses to develop their skills and improve the consistency of approach throughout Northern Ireland. These tools will help trusts ensure that patients receive the care they need, identify issues, minimise bureaucracy, enhance safety. I am committed to ensuring that the maximum dignity is afforded to people in need of services at the end of their lives. This is why I've asked the task group to work closely with the board and the Marie Curie to introduce an extension of the 7-day-a-week out-of-hours rapid response palliative care service. This is currently in the northern and southern local commissioning group areas, which covers in-hours at weekends and bank holidays, and to roll out a similar service to the northern sector of the western LCG area. This is an important part of ensuring that dignity is provided. I do not, however, want to paint a picture to this panel that we have finished this work. We have made progress, but there remains much to do, and the task force will ensure that the new initiatives are fully tested and, if working effectively, embedded in the day-to-day working practice. I recognise particularly the work of the Belfast Trust in recent months through the Impact Project. However, there are still too many patients waiting for more than 12 hours in both the Royal and Mater EDs. I also note the publication of the follow-up report by the RQIA, which highlighted that although some progress has been made to address its recommendations, by May, a concentrated effort was still required to ensure recommendations are actioned and implemented in full. I have asked the RQIA to conduct a second unannounced follow-up visit this year to provide me with an assurance of the additional actions that the Trust has taken. When I receive the follow-up unannounced inspection report of the RQA later this year, I fully expect to see significant further improvement. I hope you'll appreciate that this is a short summary, and it belies the huge commitment and tireless work of the staff of the HSC to ensure that we make the necessary preparations and improvements to how we can deliver in advance of this winter. Mr. Chairman, I understand I've only got 5 minutes, so maybe I'll leave it at that, and then any other contributions we'll make through the questions.
Jim, that's fine, and thank you for that. That sets the scene very well, and you've covered a number of issues that have caused resonance in terms of the evidence that we've had on the inquiry. I'm going to start the questions and then pass you to my colleague Marion Reynolds and then to Paul Hunt. I want to start really with 2 or 3 questions about announcements made in the last week. The first, I think as a panel, we're very interested in the review of administrative structures by your permanent secretary, and also that you obviously have in train a review of governance and accountability by Sir Liam Donaldson. And there does appear to be overlaps in part, but I think what we're interested in is what you think are the key issues that have motivated you to have 2 such inquiries, and what is the timetable for receiving and perhaps more importantly publishing both of those reviews?
Well, first of all, as far as Richard Pengelly's initiative, which I fully support, there is a general perception that there are too many administrators within the health and social care system. My difficulty in the present situation is that the vast majority of our administration costs, of course, are salaries and wages. So I have had to introduce contingency plans to balance the books between now and the 31st of March. Stripping out a layer of administration wouldn't solve that problem at all, because it would be 3 years before there'd be a payback. But there has been a more general concern expressed that in the long term we need to look at the level of administration at all levels, not only the level of numbers but also the structures, with a view to saving more money which can be diverted to frontline services. I have to say that the Health Committee 4 years ago went in with great enthusiasm to look at this and thought that they would find all sorts of issues that could be dealt with to save money. As it happened, they went very quiet, because it actually worked out that the average administrative charge is about 4.1%, which compared favourably with the rest of the United Kingdom and Europe generally. And whilst I have no doubt that there are areas where we can save money, perhaps through structures, It may not be the pot of gold that we had hoped, but any savings that Richard can realise will be very much welcome. Now, as far as the timetable is concerned, we're actually looking at getting this work analysed and running in parallel with our final budget decision for 15-16. So this really is quite an urgent piece of work. There's a possibility of some form of voluntary exit scheme being funded, which wouldn't come out of the coffers of the department. And I would be very keen to avail of that where I can find appropriate savings in management and administration, which will not affect then the forward delivery to frontline care. So it's a very challenging situation that we're in. And running, of course, in parallel with that, of course, is Sir Liam Donaldson's review. And Sir Liam, of course, as you know, is one of the most prominent and well-known individuals in healthcare throughout the United Kingdom. And his review was commissioned by my predecessor as part of a programme of actions across the HSC to promote quality and good governance. It's a very wide-ranging review which will cover a number of governance issues within the Trust. Issues such as openness and transparency when things go wrong. It also relates to the governance systems such as adverse instances, which I think will be coming to later on, early alerts, complaints, and the approach to redress and making amends. And again, very challenging. We're expecting that report in December 2014, so just over a month away. So I think it gives an indication that my predecessor took these issues extremely seriously, and so do I, in that if there are areas where we can improve, then if we're going to go into the battle for more resources for frontline care, we need to show that everything that's being done has been done effectively at management level. That having been said, I must pin my colours to the mast. I have been incredibly impressed by the quality of our administrators and managers within the health system in Northern Ireland. And I must say, I haven't seen many areas where I feel that there could be radical change in numbers unless we adopted completely new structures. And we've already only gone through an RPA 7 years ago. So we have cut the number of trusts down from 18 to 5. And we have reduced the number of boards to 1. And in that, we made significant savings. It may not be appropriate to be just so radical so quickly, but if savings can be made, then I'm determined to do so. But I could also say, even with all of this, it will not answer the fundamental point that healthcare provision in Northern Ireland and the rest of the UK is underfunded. And a recent report has indicated that we need, as a nation, £8 billion more to keep healthcare delivering what public would expect it to do. My cut of that would be 240 million under Barnett. If I had that 240 million, my first 70 days would have been incredibly more pleasant than they have been. And I certainly wouldn't be encountering so much opposition to moves to bring the budget into line. So whilst I'm very happy for both of these to continue on, and we'll take their reports very seriously, I think we need more radical steps to bring the budget into balance.
Okay. Just a very quick supplementary. In terms of Sir Liam Donaldson's report, would you intend to publish that early in the new year then? Is that the intention in terms of if you receive it before Christmas?
Well, it's the end of December, so I suspect it'll ruin my new year. I'll have to require a lot of work. Again, I want to be as open and honest with particularly the committee, the health committee, that they would get a very early sight of it, and I don't think there'll be anything in it that we can't make public. And I want to engage with the public because I have had some very good ideas put to me as to how we can improve our governance systems within the trusts and take out some levels of administration, and also our governance arrangements within the HSC. So I suspect what we'll do is I'll get a chance to look at it privately over Christmas, or at least over the new year, and then we'll release it to the committee in the normal way and ask for their views. And I suspect the huge number of NGOs that are involved in healthcare in Northern Ireland will make their views known as well.
Mm-hmm. Okay, thank you, Mike. Second question, which again is an announcement last week, which was the interesting decision to appoint Michael McBride, your Chief Medical Officer, to simultaneously head up the Belfast Health and Social Care Trust. And it did strike me as there was considerable scope for potential conflicts of interest between having a situation where you have a chief executive in the Belfast Trust on a temporary basis reporting up to the board, who report themselves upwards to the department, where you will also see Michael McBride sitting in his chief medical officer role. And I'm thinking, for example, in terms of his role in looking at how the RQIA improvements roll out, his co-chair role, where he'll now be responsible for delivering some of the things as well as adjudicating on how well the trust is doing. And I'm thinking in terms of, for example, if something goes badly wrong over the winter and under winter pressures at the Belfast Trust, hopefully that doesn't arise. But if that happens, then clearly one of the places where the Belfast Trust has to account to is the board and the department. And again, he'll have a role there. So I wondered, has there been consideration being given to those conflicts of interest? If so, what's the process for dealing with them? And how long do you think Michael McBride will be, if you like, riding two horses in terms of the Chief Medical Officer and the Chief Executive of the Trust?
I should explain the position we found ourselves in since Colm Donaghy moved on to Sussex. That's a very crucial, high-powered role in health in Northern Ireland. It's the most demanding of trusts because of the regional service it provides for so many conditions. I'll be honest with you and say that we had difficulty filling that post. Because it's not only high profile in the sense of important, but the media in Northern Ireland tend to be latch on to the Belfast Trust Chief Executive to a much greater extent than anyone else. Michael comes with a huge degree of experience. He was the chief, what's the phrase, was chief medical, what was he in the health trust, what was the actual title? He was the medical director. He was the medical director, yes, of the Belfast Trust before I arrived on the scene, and has vast experience of dealing with the hospitals, particularly the Royal. We need someone with huge experience and knowledge to go in there, because much of our performance in Northern Ireland generally is dictated with how we work, particularly at the Royal and the Mater. And indeed, our targets could be radically dragged down if we weren't performing well at Belfast level. So therefore I have total confidence in Michael. I've known him for nearly 6 years, and I have total confidence in his ability and knowledge of the Belfast Trust situation to come in there and to continue the good work that has been going on. And we are making significant progress, but we're not far enough down the line. As far as the conflicts of interest concerned is, Michael would be knowledgeable enough and professional to step back in any situation where he would see a conflict of interest, and of course we as a department would do the same. His role at the minute will be mostly Belfast Trust with a pro rata 1 day a week for the CMO, and of course he's got a very strong team of deputy CMOs who will be taking up a lot of the slack. But we felt it was very useful still to have his view of something, as you say, something dramatic happened. But we do so given the fact there's vast experience below him and the Chief Medical Officer's office. So we'll watch that very carefully. But similarly, in my own situation, I sometimes have to step back as Minister and say that, and declare that I was involved, for instance, in the Down Hospital campaign, and make it very clear, where my involvement was, so that people understand exactly what my position is. But then, of course, I still have to take decisions which are in the best interests of the country rather than just one particular constituency. So I'm confident, given Michael's vast experience, that he will watch that very carefully, and he will know he's being watched as well to make certain that there are no conflicts of interest. And if they do, then the normal arrangements have to apply. We're hoping and praying that there's no major breakout of anything like swine flu or, dare I say, Ebola, which hopefully is coming under some form of control, that we don't put ourselves in a position where we're going to have to try and take up more of Michael's time wearing his CMO hat. It is a defined contract. We're hoping that Michael will go in there and do a job and really put Belfast on a very steady foundation for the long term. And I can think of no better man. It also means now I've got a full team of chief executives, most of them relatively young for their position. And therefore we go forward with a very strong team with huge experience and ability. And we need that. We couldn't allow that situation to fester much longer where we had a vacancy in the Belfast Trust. It's just too important.
And again, just to supplement, without prejudice, as the lawyers would say, how long do you envisage that kind of temporary arrangement being in place? Are we talking about an accelerated recruitment process, or?
Well, what we're particularly interested in Michael carrying out a task is unscheduled care, the very subject we're dealing with today. Again, we all saw the situation that developed in the Royal in January 2014 and how the huge pressure that was put onto the system when the perfect storm came together of so many pressures all coming together in the 1 week. So therefore, we're hoping that with Michael's vast experience, that he can come in and deal with the winter pressures, and then we would keep the situation under review. But I want to make one point, Mr. Chairman. Northern Ireland can never provide the capacity to deal with every eventuality. If we were to build in the capacity to meet peak demand, which may only occur 5 or 6 days a year, we would then be funding a lot of spare capacity that was not be used. So inevitably there will be times when the system will be under considerable stress. We've been very fortunate up to now. The weather has been relatively mild, and we haven't yet seen the really bad midwinter pressures that we've seen in previous years. But there will be times when it's going to require a very steady head to come in there and manage the flow and to move patients around between various facilities to ensure that we don't have huge queues developing at one particular ED department. And again, I see Michael as the person best placed to deal with that very challenging situation. And therefore, it was the choice we had was to allow the situation to drift and to keep trying to recruit people, maybe from outside Northern Ireland, or to place someone in on a temporary basis who had 100% understanding of the situation. And Michael was willing to do that. I mean, Michael could have stayed as CMO and nobody would have pressurised him to do so. But Michael felt he was up for the challenge, and I have total confidence that he indeed is up to it.
Okay, thank you. And my third question around kind of last week's announcements is on resources, and you've alluded to it on a couple of occasions, both in your answers and in your opening statement. And I wonder if you could tell us about how much additional money will go into potentially accident and emergency this winter to deal with winter pressures. And then in terms of, we're aware of the announcements made last week in the budget statement about where health sits. And I wondered if you have any views on the additional monies that are now likely to come as a result of the Chancellor's announcement yesterday, and where you think some of that money should go within health, and in particular into the emergency department. So I'm interested in both this winter and next year's budget, and just what you see are the prospects for accident and emergency and the healthcare system as a whole.
Well, as you may be aware, in the October monitoring round, we got £60 million of additional resources. That came by means of a loan that was granted not to my department but to DFP and will be repayable by DFP. Of that, we allocated £5 million for extra resources for unscheduled care, and already we've had 2.3 million which has been allocated to trusts, and that's included to the ambulance service and of course to contribute towards a range of measures to improve unscheduled care. And the remaining 2.7 million of the additional funding will be allocated to the trust to fund measures to improve patient flow and expand capacity over the winter. So that 5 million, and indeed it's been allocated to specific hospitals where there's an issue, because it's worth saying that in the Western Trust this year there hasn't been a single 12-hour wait in the entire year, and the Southern Trust has had no 12-hour waits over the last 6 months. So there is real success out there in achieving our targets. So we've allocated to those hospitals that are particularly under stress. Now, regarding the announcement about the extra funding, I got no advance notice of this, neither did my department. I was listening to my radio over the weekend and I heard that the Chancellor was going to allocate another 2 billion. Well, the Barnett consequentials of that to us should be between 50 and 60 million. Depending on where you look at it. And I thought, goody, that's going to be great news. But life isn't that simple, and my understanding is there's still a decision about the executive. First of all, the indications is it could be as low as 41 million. And secondly, it's a decision for the executive as to exactly where that goes. Now, do I have a home for 41 million? Absolutely. I could find a home for that immediately in next year's budget. I could certainly find it for this year. But that's not my decision, but I can tell the panel that I will be fighting as hard as I can to ensure that a significant proportion of that is diverted to health, because we have so many competing demands. It's also worth reporting that, first of all, that's an indication that GB generally and the UK are finding great difficulty meeting their demands, which indicates to me that whatever problem we have is not specifically Northern Ireland related, it affects all of the UK. And you may have noted another report that said that to keep delivering services, we need 8 billion. And I mean, 240 of that, as I said, would be extremely helpful and would be the right quantum that I would think would need, not only to square the books this year, but to develop £110 million worth of new services next year. Because our problem in the budget is that we may have enough to balance the books, but not to develop all of the very worthy causes and intentions that we've outlined. So there's no such thing as a free lunch, and unfortunately, as much as I'd like to think I've got the £41 million in my back pocket, I don't, and I don't know what proportion will be coming our way. I think whatever happens, we're going to have to be imaginative as to how we raise additional money to bridge the gap. Because even with the full 41 million, that would still leave us about £60 million short for new services. It would be nearly 70, in fact. And we're going to have to think imaginatively as to how do we either control expenditure in non-essential services or else raise money as a health service to fund that gap.
Okay. Thank you. I want to then turn now to, and two final questions from me, to move to kind of the evidence that we've heard to date and some of the themes, and canvass really your views on a number of issues, and I'll then pass you to my colleague, Marion. The first one is that a recurring theme in our evidence has been broad support for transforming your care and the idea of funding moving to some extent away from healthcare and towards community care. And the issue has been made on a number of occasions by those who deliver the service that they often can't control who comes in through the doors and struggle often to be able to control how you get people out of the doors. But there's been considerable scepticism about whether the bridging monies for moving into transforming your care is ever going to happen. So I wondered really just to ask you whether you're still committed to transforming your care, and if so, how you will be able to make it happen and overcome, if you like, the scepticism that's out there, that it won't get off the ground in the first place.
I mean, I can understand why there is this scepticism. John Compton, when he wrote his Transforming Your Care document, could not have envisaged the incredibly difficult fiscal situation we would find ourselves in. And I suppose one of the problems in the funding schedule for TYC was that there was the over-reliance upon what's known as monitoring round money, slippage money that comes 4 times a year. So there has been an inadequate funding of the 5-year programme for implementation of TYC. Now, there have been some successes. For instance, the integrated care partnerships, with 17 of those up and running. The re-enablement of programme, particularly in the Southern Trust, has gone extremely well, and we're making very considerable progress there. We have either building or have imminent plans to build 4 major healthcare hubs. I was at the one in Banbridge recently, which is moving on very well indeed. And therefore, we're going to be able to show those as exemplars of what can be done. As far as GPs, there's certainly some of them are coming together in confederations, coming together, and already those are showing quite interesting results. But the reality is that the fundamental principle of transforming your care is that far too many people in Northern Ireland are far too far up the ladder of healthcare provision commensurate with their needs. And each time you go up a rung of that ladder, the costs more or less double. So the principle is to try and bring people down the ladder commensurate with what they actually need for adequate care, and to try to make the home the hub of care. And the fundamental way that we're going to do that is by closing long-term beds in hospitals and moving that funding down into domiciliary care. I think it's something like £80 million. Ultimately, we wish to increase funding. That has proved very challenging, I have to say, in the present situation, because to make matters difficult, even more difficult, and as I say, the definition of a health minister is someone, if he sees light at the end of the tunnel, goes out and orders more tunnel. And I have to say, at times I begin to feel like that. Well, the reality is that whilst we have been achieving about a 2% increase in real terms in provision for health service spending, or 2% increase in real terms demand, all the statistics are showing a 6% increase in demand. So you're running very fast to stay still. You're trying to keep up with demand, but also in tandem have these very, very complex and fundamental changes to how we provide care. And what I find very frustrating about my job, in the first 70 days I've been there, every day, every hour, budgets. You're constantly trying to firefight to keep services within their budgets. And then while that plate's spinning, you're trying to keep the TYC plate spinning of significant changes to how we deliver. And we're in the middle of that 5-year process, and it is proving exceptionally challenging. What I can say is that I am committed. My 3 priorities when I came into office was to continue to deliver high-level care to the people of Northern Ireland. Secondly, to keep that within budget. And thirdly, my commitment to bringing about the radical system that's required, a change system called TYC. There is nobody out there has ever disagreed that we have to go down this route. Indeed, Compton said that by 2025, if we hadn't gone down this route, the system would be totally unsustainable. It would simply crash around our ears. But we're not where we would have liked to be, and we certainly are having huge stress in getting enough money to deliver. And I've been told in the last 2 monitoring rounds in this year's budget, there's little of anything coming to the board or to the department for this, little of anything. And that puts us in a very, very difficult position, because if you can see the pain that I am suffering, trying to find £70 million just to balance the books by the 31st of March, what's it going to be like achieving more than that next year and finding the additional money we need for TYC? It really is a very, very difficult situation we find ourselves in.
Okay, final question from me. The recent further inspection of the RVH, the unscheduled care in the Belfast Trust, and I noted that the kind of issue of respect for dignity and privacy amongst those using the service hadn't still been addressed by the emergency department. And I noted equally that in the acute medical unit, it had begun to be addressed. And I wondered if you have any comments on what you think can be done in the Belfast Trust to make sure that that issue is addressed in the emergency department, and ensure that when RQI come back again, the same issue is not still applying to the way that people are treated in terms of the respect for their dignity.
Well, as I mentioned earlier, the Belfast Trust implemented a programme of measures designed to deliver sustained improvements in unscheduled care. And that programme, as I mentioned, is known as Impact. And it's a 3-year programme focused on significantly improving patient safety, experience and outcomes. I recognise that some progress has been made, and the Trust has, in recent months, has continued to experience high level of demand. And indeed, there's more 12-hour waits than we'd like. But just worth pointing out that in the Belfast Trust, there has been quite a significant drop of 12-hour waits. It's down to 701. Now, that sounds still far too many, but that represents a real and significant change in the number of 12-hour waits. And again, given the huge pressures being placed upon those hospitals, that's something to be applauded. But we need to get down. Our aim is to get that down to 0. My officials are considering an assurance provided by the Trust on the 17th of October that it has addressed the RQI's issues. And of course, we've still this second unannounced RQIA inspection to beef that up, as it were, and make certain that things are being done much better. I am content that the Belfast Trust are taking this issue very seriously. Improvements are being made. But the difficulty is, during the winter pressure period, it is the Belfast Trust hospitals that have the lion's share of the pressures. And it is going to be very challenging to continue that good work whilst meeting the concerns of the RQAA. I think, again, this is where Michael McBride comes in, because his previous post, he was in charge of the Royal. And I think that has given him an insight into where the highest level of flows occur. We're also hoping that this new policy of directly admitting elderly people to the city hospital without having to go through the A&E process will help. I'd also have to say, to be fair to the Belfast Trust, if a lot of our community would address their alcohol dependency, the demands on A&E would drop dramatically, and we could easily live within our unscheduled care targets. I am told that the Royal, after 12 midnight on a Saturday night, 80% of those presenting at A&E are under the influence of drink or their conditions as a result of drink. And this is where issues like minimum pricing have to be considered. We are placing our staff under the most horrendous conditions as a result of alcohol abuse. And the Belfast Trust takes the bulk of that damage. And I think we need to work as a community to stop our staff having to endure, and that's the only word I could use, to endure that trauma they've experienced as a result of drink. And then we wonder why we've difficulty attracting middle-grade doctors to staff late-night A&Es in our major Belfast hospitals. I think it's self-evident the abuse they receive is really totally intolerable.
And before I pass you on, in terms of the alcohol dependency issue, have you any particular ideas or thoughts about how that might be tackled?
Yes, I do. And along with my colleague Mervyn Story, we have been working behind the scenes to implement a policy of minimum pricing. I make absolutely no bones about it. I believe that minimum pricing is absolutely essential. The University of Sheffield report has shown that each 5 pence rise in the unit price has a dramatic impact upon the abuse of alcohol. It's a policy that will have very little effect whatsoever on the social drinker, but will mean that the prinkers, and this is a phrase I didn't know about until a week ago, prinking is preloading with drink. It's those younger members of society generally who go and buy very cheap alcohol in our supermarkets and then preload with alcohol before they go out and buy more expensive drink in clubs, pubs and discos. And all the evidence would show that unit pricing, perhaps 40, 45 pence as initial price, will have a dramatic impact on prinking in Northern Ireland, and therefore people are less likely to present at A&E. And we have 3,000 people in Northern Ireland at the moment being treated for alcohol dependency at some level within the healthcare system. We have 290 deaths as well as a direct result of alcohol. And I am not against, as people will know, I don't drink, but I have nothing against the social drinker who has a sherry with his lunch or whatever. But we really have to stop this relatively recent trend of binge drinking in Northern Ireland. A few months ago, I had a meeting with the top liver cancer specialist in Northern Ireland, and he told me that there's an extremely worrying spike in liver cancer in 40-year-olds in Northern Ireland, 40-year-old males, directly linked to binge drinking in their teens and 20s. And coming behind them, 5 years behind them, are girls, women, with liver cancer. A very expensive, a very dangerous and extremely painful and often fatal condition. And that is a result not of alcoholism, because these people do not drink Monday to Friday. These are people who go out at weekends and drink intensely over a very short period and put huge pressure on their liver. Those conditions are not only very painful and often fatal, but put a huge burden upon cancer services. So therefore, unit pricing to me is a nil-brainer. We have this issue of the referral by the Scottish Executive to the European Court of Justice, but we're going to go ahead and make preparations for that on the basis that that decision will be favourable. If it isn't, we're going to have to maybe alter our policy. But to me, it is a complete nil-brainer, and I made very public comment about it at our party conference last week. I see that as the way forward to bring this situation under control.
Okay, thank you. I'm going to pass you to my colleague, Marion Reynolds.
Good afternoon, Minister. I have 3 questions. First is on A&E waiting list times. The second is on commissioning arrangements, and the third is on claims of a bullying culture. In relation to A&E, there's probably 3 aspects to this question. In the evidence that we have received from clinicians and the trusts, there's been some concern about the utility of the 4 and the 12-hour targets in accident and emergency. And could you outline the basis for setting those time targets? What resources and support systems were put in place to underpin their implementation in Northern Ireland? And what your department assesses as the quality outcomes linked to meeting those targets?
Well, first of all, the targets are been set on a UK-wide level. They're also used in England and Wales. And I obviously wasn't party to why those particular numbers were chosen. I can say that last year there was a 44% reduction in the number of 12-hour waiting times during the year. And I'm pleased to report that in the first 6 months of 14-15, we are now at the lowest number of 12-hour waits in 5 years. I accept that they can be regarded as a rather crude measure, because obviously quality of care as well as how quickly care is implemented is also an issue. And I do believe that the department's work has shown that targets have actually led to the reduction in delays in EDs. And time is important. The time between first arrival, diagnosis and treatment produces much better outcomes. We know that for certain. But we've also introduced in 2014-15 new performance indicators designed to provide a more comprehensive view of the care being delivered in emergency care departments and to more accurately reflect the patient's experience and safety, including the effectiveness of the care they have received whilst in the department. I also should add that there is a marked difference between how we measure 12 hours, the 12 hours in Northern Ireland compared to England. In England, the clock starts when a decision is made to admit the patient. In Northern Ireland, it starts as soon as the person registers in the ED. So it's important we're not actually comparing like with like. Therefore, I don't think we can compare the performance of the two parts of the United Kingdom. But whilst it is a crude tool, what we do know is that there's something has gone seriously wrong if there's over 1,000 patients a year waiting in an ED for more than 12 hours. Also, as the Southern and Western Trust has shown, that if you can get it well below the 12 hours, that the overall performance is improving. So I still regard it as important. I remember being at a health conference in the Millennium Theatre in Londonderry one day and noticing a certain chief executive answering her phone and rushing back to her headquarters because they had breached a 12-hour target for the first time that year. And that's how seriously she took, maybe that's almost giving the person's name away, but it shows you how seriously that she took her sort of very strict orders that there should be adherence to 12 hours. So I think there's still merit in keeping those figures, because if we simply say, well, we'll just have good treatment and we don't have any tangible, rational way of measuring that, then I think we allow ourselves to slip back into the situation where the weights were just totally unacceptable.
And were resources and supports put in to allow those targets to be met in Northern Ireland as there was in GB?
We've put in the 5 million because clearly we could see there's going to be a problem. So in the monitoring round, where there was numerous bids for that 60 million, we put 5 million of it into particular areas where we thought there was going to be real stress. But I also got to say, I've noticed the Southern Trust's way of dealing with this, where they've had a fundamental overhaul in patient flow patterns, have shown that if best practice was introduced right across the trusts, we may actually be able to improve within that relatively small budget increase. Next year, we're just looking at the budgets for next year, and obviously we'll be looking, do we need to pump further resources into unscheduled care to ensure that we cut down the number of people who are waiting. Just remember this, for every 1,000 people that access either clinical, GP or hospital care in Northern Ireland, 998 walk out happy and 2 complain. It's 0.2% complain. There's only 6,840 complaints last year. So we have to accept the vast majority of people, and by the way, McDonald's or Microsoft would give their left arm for that sort of a level of customer satisfaction. So the vast majority of people who access our services are very, very happy and compliment us on it. But you and I will only hear from the 2 out of the 1,000, not the 998.
If you turn now to commissioning arrangements, Minister, we've heard claims that the commissioning process is a fairly top-down process, and the reason and the rationale for the commissioner-provider split was to contribute to competition in the health and social care sector. And I'm wondering, can you comment on to what degree you feel it contributes to competition? And could you also go on to look at how the arrangements contribute to the sharing of good practice across trusts?
I have to say I have heard that. I must say, in my initial view on it, there's quite a lot of merit in that argument. We have a new system, and I suppose to some extent we haven't given it a fair wind in terms of seeing how successful it's been. We've slimmed down to the 5 trusts and the board. And I don't see a huge degree of evidence of competition, to be honest with you. I just, I don't know if that has worked particularly well. But of course, the benefit of having a board that and the local commissioning groups does ensure some level of consistency between areas as to how we care for those who are vulnerable and drive forward improvements in health and social care and well-being. I think it's something we need to look at. I mean, is this an effective model? Is somewhere like Northern Ireland, is it the right size and there's the right demand to warrant the structures that we have? Commission is not merely a top-down process. It should also be engaging the public, patients, clients, carers in the final say about how the services are used. But I think it is worthy of further examination to see is that the best structure for somewhere the size of Northern Ireland. And whilst there are many, many folk on the board doing outstanding work, and we will still need to retain that expertise, I think it is worth just having a look at those structures to see if they're delivering the most cost-effective and high-quality care for the people of Northern Ireland. But also I'm a wee bit hesitant because after only 7 or 8 years, is it fair to make that assessment when we haven't really given it time to put the bed in the way we had anticipated?
Can I turn finally to my last question, which is there have been claims of a bullying culture in relation to A&E. Now, we have received conflicting evidence. The unions quite clearly saying there has been a culture, management side, and the trusts saying that they're not aware of it. And I'm wondering, what is your view on the likelihood of a bullying culture existing within A&E departments?
I served on the Health Committee for 5 years, 3 years as chair and then 2 years as vice chair, and I constantly met health service employees, both off and on the record. And whilst there was allegations in one particular area, which I think have been addressed, I honestly didn't feel that there was a systemic culture of bullying within the trusts or within any part of the health and social care system. And we do have an official whistleblowing policy, and recent research has shown that a very high proportion, over 70% of our staff are aware of it and would feel confident in using it. And whistleblowers do certainly show themselves frequently in various levels of the trust hierarchy. And I honestly feel that our chief executives, the team we now have, do encourage a spirit of openness about things like workload pressures, and there's effective engagement between clinical and non-clinical staff and a better multidisciplinary team approach and project working. I think it is gradually fading away as an issue. I think whilst we must always be mindful of it, I don't get a great deal of impression that it's a widespread concern. I would once again say to staff, if they feel that issues are being covered up, yes, do initiate the whistleblowing policy. Do. And it's one of my rules in my department to make certain that folk feel free to do that and don't feel that they're going to be sort of penalised for doing so. But I think the vast majority of the problems in our health service is not bullying, it is demand. And what is making staff feel at times downhearted is the fact that the sheer pressure and weight of numbers that they have to deal with. And I suppose to some extent they could interpret the fact that that pressure has been put on them as being trying to do them down, when in fact it is simply that the numbers are so intense and so large that they're finding it very, very hard to deliver a first-rate service in the time that they have. So I mean, and my door's open. As you know, I'm easily accessible on Twitter and email and Facebook. I'm too accessible. And if there's concerns out there, people will frequently let me know. But I would follow due process and take it through the normal channels. One thing I can say, in my first 70 days, I have been shocked about how few of these has been. I really am quite surprised. I would thought that, people call me everything under the sun, but it's normal about the allocation of resources rather than lack of contentment with care, or staff feeling that their voice isn't heard. And in Northern Ireland, very little happens without someone knowing about it very quickly. We're a very small, close society. So it's not, to me, one of the major issues that I'm facing. And I think the Pacific area that was referred to is now being dealt with very effectively.
Thank you very much, Minister.
Jim, I'm now going to pass you to Paul Hunt, who will complete our questions.
Good afternoon, Minister. Many thanks for your time this afternoon.
No problem.
First, a brief comment about serious adverse incidents. And when I view this process of SAIs, I think I sort of discern three sort of sets of expectations from three different constituencies. Firstly, in relation to SAIs, there are expectations of the health professionals that this will be a learning process, it'll be a learning tool, and that's terribly important. And then I think I also see an expectation of families who've been caught up in whatever's happened. And they have an expectation, they want to know what's happened, and they'd like to be involved in the process. And that too is a very legitimate expectation. And then I think there's a third expectation, and it's the expectation of the press. And the very title, a serious adverse incident, that sort of underscores this is a very weighty matter. And I think I see there's an expectation that the SAI serves as a process to find out what happened with a view to accountability. And that too is a really sort of legitimate expectation. So, I mean, if I've got it clear, and I'd be really very genuinely interested in your view, I think there are these sort of three legitimate, very honourable expectations of the health professionals, of the families, and of the press in relation to a serious adverse incident. And I suppose I'm just wondering, can one process, is it realistic to expect one process, the SAI process, to carry these three roles and these three expectations? And I wondered if you had any brief reflections on that.
Well, as you know, the SAI system came into place in 2004, so we've had it for 10 years. And I think it's very important that the public and the media and patients actually understand what SAIs are designed to do. They're not to apportion blame to any group of staff. They're to identify and disseminate learning. And the reality is that we need a spirit of openness for people, staff, clinicians to come forward and report serious adverse incidents. And clearly, if it gets to the stage that our response to that is to apportion blame and take action simply as a result of that being reported, well, for very obvious reasons, the flow of information will slow down. Now, that doesn't mean that if you have an SAI, something might lead on from that in terms of an inquiry. And the hyperemia is a good example of that, led to, much further investigation. So I feel it's a good way of knowing if there's something radically wrong going on out there. The Pseudomonas was a classic example where we were getting a series of SIIs of very, very unfortunate situations arising with very vulnerable babies. As a result of that, Edwin my predecessor, announced a very fleet-of-foot inquiry, which got to the bottom of that situation. Steps were taken, and I'm glad to say that issue has largely been eradicated from our hospitals. But it's a system that's well known within the UK. And as you know, Liam Donaldson, as part of his remit, is having a look at the whole efficacy of the SAI system as part of his overall review and his assessment of wider systems for learning from the system. So therefore, I would be very interested to see what he comes up with in terms of, we've had these for a decade, do we need to expand upon them? Now, the press have a totally different idea. The press see SAIs as being almost something that is used as a tool to eradicate staff who are underperforming, or a tool that's used in disciplinary hearings. I don't think they really fully appreciate what's going on. But equally, I was involved in the Dundonald Hospital as an MLA with a very serious SII, which then led to a full inquiry by the Trust and a report which set out exactly the reasons why there was an extremely unfortunate situation where a young man died. So I think I should hold fire on this to see what Sir Liam, who of course is so preeminent in these dealings with this, what he reports and what he says. And as this is coming to me by the end of this year, I think it would be wrong, I think, for me or anyone else to preempt his decision on them.
Thank you, Minister. In your written statement to the Assembly, which you referred to in your oral remarks, this is the written statement of the 19th of November, there's a section which I found really instructive, headed Values and Principles, in which you explain that your department is developing a values and principles statement that will underpin the development of future policy and service delivery. And speaking personally, I think that's a very welcome initiative. Could I briefly comment and then ask a question, if I may? As you know, Minister, the UK has ratified a number of binding international treaties that include the right to the highest attainable standard of health and other health-related rights. And in fact, as you might know, next year the UK actually goes to Geneva to appear before a UN committee to explain how it's implementing these international obligations. And these obligations, these international human rights treaty obligations, are animated by a whole set of values and principles. And these human rights values and principles have received a lot of careful attention by the UN and many others over many years. And now I'm pleased to say there's actually some hard evidence that explicit human rights language does contribute to health improvements. Minister, over the summer when we've been receiving evidence, we've heard that trusts and others are driven by a set of values like dignity and equity and quality. And we've also heard evidence that human rights are implicitly, but not explicitly, taken into account by trusts and others. And I have to say, I find this a bit strange because there is so much overlap between the UK's international human rights values and principles and the values and principles articulated by trusts, as we've heard evidence of over the summer. So, my question is, are you open to your department's values and principles statement explicitly drawing from the UK's international human rights language and standards along the lines of the NHS Constitution in England?
First of all, my colleague, Mr. Johnson here, must be feeling very aggrieved. He hasn't had a chance to have a word in Edgeways throughout the entire hearing, and I don't want to encourage wrath. And Jackie would be more up to date with this than I would, so I'll bring him in just in a minute. But what I can say is that whilst clearly our primary aim is to provide the best possible health care for the people of Northern Ireland within the budget we've been allocated and ensure an increasing improvement in outcomes, I am slightly worried about putting direct reference to various international treaties and I think that what's the phrase is conventions into statements, because we live in a very litigious society, and I would be worried that we would spend huge amounts of time defending various cases. Whilst we might be delivering very good health care, there would be those who would tend to use that as a battering ram against us. And we spend a huge amount of money already dealing with legal actions. Litigation is a huge part of our service, unfortunately. And indeed, one of the reasons why we got into such difficulties in 13-14 was that many of those negligence cases came to fruition during that financial year when we had to arrange the payouts, which we self-insure. We don't have insurance for this. So whilst implicit in much of what we do are basic fundamental human rights of dignity and quality of care, I think that's best done through a more general, we want to do what's best for our people, rather than enshrining it within any constitution where immediately it becomes a litigant's charter and where people will, at the drop of a hat, unfortunately, use scarce resources by suing us for what they believe is a fundamental breach of their human rights, which may be that maybe a resource issue rather than any intent to do down a particular community or section of the community. Because the vast majority of problems I face are not any willingness amongst the trust to do the absolute best for their community. It's the lack of money to provide the high level of service that they want to. And I think issues like, I think there's no suggestion, for instance, when we've got 10 A&Es in Northern Ireland, that we don't have a spread amongst all communities, that everyone has reasonable access to high-level health care. But I'll put you on to Jackie here, who's more across the sort of the deeper philosophical parts of this particular question.
Yeah, I think in response, what I would comment is it seems just that a human rights-based approach would seem to focus on the application of some core principles. For example, accessibility, participation, equality, non-discrimination, quality and accountability. So we haven't, as it were, finalised our draft values and principles yet. We'll be going out to consultation, those subject to the Minister approving them within the next month or so. And we therefore would welcome the views of the Commission and the inquiry on the draft document that goes out. And anything that you would have to say, obviously, we would want to take into account before we finalise that. So at the moment, we have no explicit commitment. I think you'd ask, were we going to explicitly commit ourselves to an approach? There's no commitment to that at present for the reasons the Minister outlined. But we would be interested in hearing your views and giving them careful consideration before that document be finalised, and we'll have the usual 12 weeks consultation, and then we'll consider the representations before the Minister would sign off on the final set of values and principles. But certainly the overall approach would be try to underpin the issues that are referred to there as we go forward and develop policy in this area for unscheduled care.
And certainly we would welcome any view from the Human Rights Commission of how we can take this forward in a way that doesn't encumber the huge amount of work that's being done already, that we try to get a balance that meets your concerns about human rights, that doesn't leave us in a difficult position, because the vast majority of our work must be delivering care for those who need it, rather than constantly worrying about any sort of conventions and controls on what we do. And also, you have to remember that some terribly difficult decisions have to be made. I'm extremely unpopular in places like Bangor and Ballycastle because of decisions are made. I would be worried that decisions that were taken on the basis of clinical need or on the basis of finances weren't immediately challenged because we'd signed up to something that really is being used as a tool to oppose this, rather than a genuine concern about the human rights of the individuals concerned.
Yeah, thank you both for those comments, and now's not the time for a detailed discussion on it, but if I could very briefly and respectfully make a couple of points. There's been a real change in the last 5-10 years in thinking about a human rights-based approach to health. It used to be framed as a litigant's charter, as you put it, Minister, but there's been a real shift in a number of jurisdictions, and certainly in the United Nations, where it's now constructed as a tool, as an asset to help health professionals fulfill their professional objectives. So now the emphasis is on how human rights can help, how human rights and health rights can be operationalized in health systems. And there's quite a lot of literature on this now, and there's been a real shift. And in some jurisdictions, it's been extremely helpful, in Scotland, for instance. Without taking up too much time on this, in the NHS Constitution of England, there are some human rights principles there which are set out without providing a litigant's charter, as you put it, Minister. The final point I'd make is that within international human rights law, the right to health is subject to maximum available resources, and it's subject to progressive realization. So it's understood that this stuff is going to have to be rolled out, contingent upon the availability of resources. But nonetheless, many people now consider that this human rights language introduces some elements which health professionals can find extremely useful. But perhaps thank you for the invitation to a willingness to listen to my colleagues from the Commission, and perhaps this is a forthcoming discussion. Do I have time for one final question?
Yes, yep.
Minister, it's about participation, and I'd welcome your guidance on this, and I'd be very interested in your views. And it seems to me that there are some very good participatory practices in the Northern Ireland health and social care system. By which I mean practices that enhance the participation of the public and professionals and communities and families. And I'm not going to list them all, they're too numerous to list.
I think there's 22 at the last count. 22.
So there's 10,000 voices and others. But still, I've got the sense, and it might be from that comment you just made, that you have a different view. But I have the sense that, notwithstanding these practices, the system, when I step back and look at it, it still seems to me to be quite top-down, not bottom-up. And I'm wondering if, now please notice the next bit, without introducing a new layer of organisation, not interested in that, but I'm wondering if, without introducing a new layer of organisation, local participation in the health system could be deepened. And let me be specific. And I'd be interested in your views. For instance, as I understand it, each trust has 6 non-executive directors. And I'm generalising somewhat, Minister, but I have the impression that often those non-executive directors do a really important job in a sort of professional capacity. They're there because they've got some background in law or accountancy or possibly some aspect of a medical profession. And don't misunderstand me, I think that's a really valuable role. But what I'm wondering is whether or not perhaps 3 of those 6 non-executive directors could be charged with in providing a sort of conduit between trusts and communities, whether a way of ensuring that the views of communities, the concerns of communities are fully articulated in the trust. And I'd be interested to know, I suppose there are 2 points. Generally, do you agree with this idea that it's a somewhat top-down system, could be more bottom-up? And secondly, the very narrow, specific consideration that I've just put on the table about a slightly different role for 3 of the 6 non-executive directors in the trusts.
Well, it's an interesting idea, and one I haven't heard before. It wouldn't require any legislation. It just could be a policy implementation by the trusts.
Indeed.
It's one I'd like to take back and consider. I don't think anyone could allege that Northern Ireland does not provide sufficient opportunities for participation. We've got the Health and Social Care Councils. Each trust has a body which has got local government and activists on it. We've got the Patient and Client Council under Maeve Hulley, which deals with many issues. You've got the board members you've mentioned. You've also the Health Committee, which has been there now for 16 years, which reacts very much as a sounding board for the concerns of individuals. I probably answer more written questions than every other department put together. It feels that way. I think it's running at something like 35 a day at the minute, coming in vast amounts. And certainly when, for instance, there was an issue about hospital reconfiguration in the Northern Trust, I've just been handed a petition signed by 19,000 people from Moyle District Council. There are only 22,000 people live in Moyle District Council. So that indicates to me that over 90% of the population have expressed their view. And I'm certainly getting the message that there's concern about that decision. So I think Northern Ireland's a small place, and if there are concerns, people are very quick to mention to them. Also, the 108 MLAs, their district councillors, their MPs, and a myriad of other organisations like the Fire Brigade Union, people like that, a Fire Brigade Service, which also has non-executive directors, all of whom are having an input. And I mean, if my post bag's anything to go by, people are very aware of the situation, very quick to articulate their views, and there's no hiding behind the bush. Because if you want to see 10,000 people in the street in Northern Ireland, don't have a political issue, try to close a hospital. That's when you have the huge public participation. So I think your idea has some merit as a relatively cost-effective solution. But you find that, again, the vast majority of people are happy and only get exercise when their local service is under threat. That's when you get the public engagement. The vast majority of the rest of the time, they're perfectly happy just to read their local newspaper and to read what's happening up at the Assembly. But I think if any region in the United Kingdom, there can be none that has so much in the way of participation and engagement. And everybody in Northern Ireland has a view, because they're either working for the health service, 70,000, or else there's somebody who's been treated by the health service. So I can't go to Tesco's anymore, because if I do, I spend the entire day in the fruit and vegetable answering people's questions about health. People are very quick to engage and to give you your views, sometimes not very complimentary. So beyond that level, I don't see there's a need for a new layer of consultation, because in 1.8 million people, some would believe, in fact, we're over-consulted. And remember that the vast majority of the decisions I make are on resources and money. And people will always say, the approach I'm getting at the moment is, I agree totally with all your cuts apart from mine. Or you should cut everything in this service in Northern Ireland apart in my area. It is not that they don't feel they've been consulted about or understand. They're just aggrieved that I haven't got enough money to keep all of the services in their area. And I don't see how greater participation would change the fact that I'm still 70 million short between now and the end of this year. If consultation got me that money, we'll bring it on. But the reality is, at the minute, that's the issue. And when we get the money, people are generally very content with the service they get.
I didn't use the word consultation, but participation.
Well,
I think there's an important difference. And I'm talking about something a little bit more formal than meeting the minister in the aisle at Tesco's. I was just wondering if there could be greater involvement and therefore greater responsibility, importantly, from communities, greater involvement in communities, not just consulting, but greater engagement and participation by communities in a bottom-up way in the health system. And with participation, genuine participation, comes responsibility, actually, and a deeper understanding of the immensely complicated and difficult decisions that you and your colleagues are confronted with. So it wasn't so much consultation that I was talking about, as more a sort of community-based participation in the health care system.
I have to say, in this last few months when we've been going through very difficult decisions, I have yet to find any local community that takes the wider picture. Nobody comes to me and say, look, you're having to downgrade our facility, and we understand, because you think of the bigger picture of our trust or the country. Everyone simply says, we want to retain our service, and our service is so important to us, it shall not change. And I don't know how, by further participation, you change that view. And I have had, I dare tell you how many thousands of communications over this last 3 weeks about this issue. And not one of them, no matter how participative they've been, thinks that their service should go. And I think that's the nature of democracy. And even in England, you had MPs elected on one issue, hospital closure. We had an MLA here elected on a hospital closure issue. And in the Republic, that's quite common. So I think it's inevitable that people will want to retain their community's services. I'm certainly, people may feel that they participated in that decision and understand it, but they'll still object to it. And that's just the reality of the situation we're in. There can be no popular decisions on health, as I've discovered to my concern. But certainly, I think it's worth looking at. I don't know whether Liam Donaldson in his report will allude to it or not, as to whether there should be more participation or consultation or more community involvement. But if you look at any local newspaper in Northern Ireland, and we do have a lot of local newspapers, you will find that there's an incredible level of participation, mostly with a picture of me in it, calling for my head to roll, or my predecessor's head to roll. There's no lack of engagement or knowledge of the situation, but do they end up agreeing with me or agreeing with the more general nature of health service pressures? No, they don't. They don't.
Minister, thank you. I want to give you the chance of the last word. Is there anything that you think we haven't covered, or anything that you'd like to say before I close this particular evidence session?
There's a couple of things I felt I should have said in the concluding remarks. As I say, the most difficult area for me here was this issue of incorporating human rights. Certainly as far as the spirit and ethos of human rights, there's absolutely no difficulty with ensuring that those fundamental values and principles should guide our approach. And we should learn to work nationally and internationally in this regard and benchmark our values against what is best practice in the rest of the democratic society. I think we must also continue to establish partnership between patients and underline the need for mutual respect and facilitate more information and choices for patients. We also would like to ensure that patients take greater ownership of their own health and well-being. And we also need to move closer to communities, as the point you made, where we live and interact. I would need to be persuaded that we could go much further than that at this point, but equally, one of the values of your report may be that you can convince myself and others that this is indeed something that should go beyond simply having an aspiration or support for, and should become more solidified in some form of constitution. But I have to also be honest with you and say that the next 18 months we will be concentrating entirely, or almost entirely, in firefighting, in trying to stem the rapid rise in healthcare demand and match it to a finite resource. And I would love to be saying here that I'm going to spend the next 18 months dealing with much wider and much more strategic decisions. But I would be fooling the people of Northern Ireland if I didn't say that the vast majority of my time will be spent trying to balance the books in a way that leads to the best possible patient care. And whether at this stage we need to have the incumbents of further controls on what we can do, given the fact that very few people out there are really concerned about human rights, they're concerned about the delivery of services. I'm not so certain that's what we need at the moment, but I'm very open to your suggestions.
Minister, thank you. I think you've laid down a very useful challenge to us. I hope that our report will be practical and valuable in what I call applied human rights. And one of the things I'm sure our report will look to do is to set out what a human rights framework might look like in terms of service delivery for an A&E, and to see, hopefully, post the report, how that might work. So I hope we have an opportunity to change your mind on that. I'm fascinated that you're the only person in the land who's looking for £240 million for Christmas, and good luck with that. And I wish you really well with your endeavours in what is one of the toughest jobs in politics, and good luck, because clearly the well-being of Northern Ireland is in your hands and those of your officials and colleagues that plan and deliver the services. So wish you well with that, and thank you for coming along this afternoon in what is, I know, a very busy day for you. So thank you very much indeed.